Well, hello and welcome to the 27 Degree with Chris and Nancy. We would like to welcome back again neurosurgeon Dr. Alvin Marcovici to our podcast today to discuss neck pain. We're really thrilled to have you back. Thank you so much.
And I'm thrilled to be back. Thanks for having me.
Oh, you're very welcome. And before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare. Hearing healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit duncanhearing.com. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform and by following us on Facebook and Instagram. Also, please remember to follow and leave a review. 5-star reviews are greatly appreciated. So before we get going, tell us a little bit about yourself for those who did not listen to the first podcast we did with you.
Well, my recommendation is go back and look at the first podcast. But if you've missed it and are absolutely...
And it was a great podcast, the first one.
I think so, but I'm biased. But if you want to watch this one before going back to the first one, I'm a neurosurgeon. I first went to college in Waltham, Mass. And then I did my medical school training in New Haven. And from there, I did a neurosurgery residency in New York City at the Albert Einstein program. And then I changed things up and did a orthopedic spine fellowship to get a different perspective on the spine also in New York at Beth Israel, in Manhattan. So I've lived my entire life and career up and down this 95 corridor. So I know a lot.
A lot of training.
A lot of training. Neurosurgery is a very long training process. And as you can imagine, if you're going to operate on the brain and spinal cord, it
makes sense.
Yeah, absolutely. You want someone who's had a significant amount of experience. So most spine surgeons, whether they're orthopedists or neurosurgeons, have had 7 years of experience by the time they're operating independently.
So that's 7 years after medical school, just to
7
clarify.
years.
So
Correct.
It's quite a long time.
Yeah.
Yeah.
That includes the 4 years of college and 4 years of med school on top of that. So.
Right. That's wild. It's got to be one of the longer residency training programs. That cardiothoracic surgery, I would think, is up there too.
Cardiothoracic is 10, even though I think, and I may be mistaken, they're trying to shorten it a little bit. They used to do a complete general surgery residency before they did cardiothoracic.
Wow.
So they're the longest, I believe. And then neurosurgery is also pretty long, 7 or 8 years.
Wow.
So last time we spoke about the lower back, and it was a really great podcast. For those who haven't seen it, please check it out. I think it was really invaluable. And, back pain is so common that I think a lot of our viewers will resonate with the podcast. But today we're going to talk about the neck, and then we'll have you back for part 3, our neurosurgery mini-series, and we'll talk about the brain. But yeah, let's talk about the neck, because neck pain and neck issues such as that are very common. We see that all the time. I see it in my practice commonly. And do you see more neck or back issues?
So I think as far as what is most common, back, because the back is at the bottom of the spine and the body, so it tends to carry more weight,
right,
and therefore it degenerates faster. We talked in our last podcast that back problems are part of the spectrum of what we call degenerative disc disease or degenerative joint disease, and it's part of arthritis. And so low back pain often comes with neck problems too,
Right.
which also often comes with shoulder problems, hip problems, knee problems. As we all get older, we start getting this arthritis, and really the neck goes hand in hand with the back.
Yeah, I would think, just thinking back, I mean, most of the patients I have who come in for severe back issues have some neck issues, or vice versa. They do go together, don't they?
And quite often I see patients who have both, and I have to say, okay, if you had a magic wand and could only get rid of one, which do we have to take care of first? Unfortunately, because we have to jump through hoops for insurance and stuff like that, it's often very difficult to address both at the same time.
That's really interesting. So I was just going to ask you that. So if someone does have back pain and neck pain, you can't kind of treat them together just for the reasons that you stated?
You definitely can, and you should, we should as physicians. But because of the regulations and limitations and authorizations that we need to obtain, it can often be very difficult to obtain an MRI for the back and the neck simultaneously, or physical therapy for the back and the neck simultaneously.
It's difficult. I often have patients who come in and they say, "Can you just MRI my whole body or my whole spine?" And
the old body scans. You even get cards for in the mail.
Yeah, you can't really, get insurance companies to cover that.
Right.
So it's also a lot of time in the machine too.
It's a lot of time in the machine, and the MRI companies don't like it when you order 3 scans, because if for whatever reason you no-show, they've now got 2 hours of machine time that's empty.
That's devastating to them.
Well,
So
I wouldn't say devastating. The MRI companies do okay.
Yeah, they do all right.
They might still charge you for a no-show too.
Yeah.
So if you're treating, if someone has neck and back problems, do you typically do the back first, or is it really dictated by what's going on in each area?
Well, this is the most important thing to take away, that back problems almost always result in back pain, and that troubles people a lot. Neck problems don't always cause pain, but oftentimes can be more serious. And the reason for that is our spinal cord, which attaches our brain to everything else, actually stops in our mid-back. So in our low back, we actually have no spinal cord.
Okay.
It's just nerves there. And those nerves can cause a lot of pain, but very rarely and only under unique circumstances would they cause someone to be paralyzed per se.
Right.
Neck problems have the spinal cord and affect everything below it.
Right.
And because of that, neck problems can often be much more dangerous. What makes that especially dangerous is the fact that sometimes severe neck disease may be accompanied by no pain at all. And that's because the spinal cord itself doesn't have any pain fibers. So you could cut the spinal cord in half and not cause any pain. So unless it involves a nerve, the spinal cord itself doesn't cause any pain. And some people could be tiptoeing on the edge of being paraplegic or quadriplegic, and oftentimes not even know it.
Wait, so back up a minute. Like, would they have had like an injury or something? Like, or does that just like happen?
So a lot of times it's from an injury. So if there's an injury and all of a sudden someone has problems, it's pretty easy for us physicians to laser in and diagnose what the problem is. What really becomes a challenge is when it's a slow creeping buildup of arthritis and you have pressure on the spinal cord, and people may not even know it. And it just slowly builds up. And
So they may present with weakness, for example, but no pain is what you're saying.
Exactly.
Yeah.
And
will there be something, like they're not just going to be totally asymptomatic if something's going on, are they?
in the early stages, they may be totally asymptomatic.
Really?
Yep. And then they sometimes present only in very late stages, and they may have been completely asymptomatic until it gets to that late stage. The brain and the spinal cord have remarkable abilities of compensation. So they there's a little pressure and the spinal cord compensates. There's a little more pressure and the spinal cord compensates. And then it reaches a point where, the straw that breaks the camel's back, the spinal cord can no longer compensate, and people can have a relatively rapid decline, even though it's a problem that's been there for years.
I always found that amazing how well our body compensates for things that we do. It's it's so well designed as just like a machine, But so when we're having problems with our neck, can you tell us what the oh my God symptoms are you should really be seeing soon?
So this is very, very hard to explain because sometimes these problems can masquerade as many other different problems. And I've seen too many people to count who have presented with sort of red herring symptoms. So for example, people who have difficulty walking. The list of symptoms that cause people to have difficulty walking, you could have neuropathy or blood pressure issues or, dizzy spells. And so if you have difficulty walking, anybody who's listening to this and you have a little difficulty walking, don't run out and get an MRI of your neck. But your physician should be thinking of it. And quite often it's neurologists who diagnose the problem. Or sometimes actually people have difficulty walking and people think that there's a leg problem and they send people to me because they're thinking, oh, the legs, something's wrong with the legs, must be coming from the back.
Right.
But yet the MRI of the back looks fine.
Well,
And it takes a little bit of insight and a little bit of experience to say, well, let's take a look at your neck. And that's when you can often find it.
So it's a little tricky then, because sometimes the symptoms are like they could be a little bit of everything, and you probably would think like it's like a little puzzle that you have to put together initially when someone comes and talks about something, especially you think it might be something, you send them for a diagnostic test, it comes back negative, and then you're like, well, what do we do now? Do we look at something else or?
Yeah. These are the challenges
yeah.
that physicians face every day. People don't come in with a sign on their chest saying that, I'm having a heart attack, or we're often experienced at these masquerading symptoms. They always tell us a heart attack can present with pain in the left shoulder. And similarly, neck problems can be very difficult to diagnose. They're much harder and oftentimes much more dangerous than low back problems, which really present themselves pretty clearly. People with back problems, people with problems with pain shooting down the legs, sciatica. It's pretty easy to figure that out.
Is the neck more delicate to work with?
Much more delicate because you have the spinal cord. So in the low back, you can operate almost on the front of the spine by just moving the nerves out of the way. You can't do that in the neck because you can't move the spinal cord out of the way. If you put a lot of pressure on it, you're going to damage it. So we have ways of operating on the spine from the front of the neck or from the back of the neck, or sometimes both.
And if you're going through the front of the neck, there's just so much there that you have to be careful with the carotids, vasculature, et cetera.
Yeah, so you have the carotid artery, the jugular vein.
Tricky thing, I'm sure.
Sure. And then one of the people often don't think about it, but one of the most common or dangerous things to injure in the front of the neck is the esophagus. So if you have a neck problem, the last thing you're thinking of is your swallowing ability. But quite often, that's actually the most common complication.
How do you damage your esophagus?
So the esophagus is a very interesting organ in that it doesn't have a very thick lining.
Okay.
So most of the muscles in our body have a pretty thick lining called a serosa that protects it. The esophagus does not have that. So it's easily injured, either by the retractors we put in or by the instruments we put in. And you have to move it sort of out of the way to get to the spine. So it's sometimes damaged. And if it is damaged, it can be very, very troubling. And even if it's not damaged, even if the operation goes just fine, the most common complication, take that back, the most common complaint I get from patients is trouble swallowing just from moving it. It's very, very delicate, and, we often don't think about it. We take our swallowing for granted, but once you mess with it, it can be very uncomfortable for patients.
Yeah, that can be. I mean, I just saw someone today. They had a head and neck cancer. I know it's a little bit beyond what we're talking about today, but he had just had radiation. He's actually going through radiation therapy right now, and the complaint is always the same, and it's troubling for patients. They can't swallow, and they're really dry. They have no secretions anymore because of the radiation's effect on salivary function and whatnot, and the swallowing has to do with the effect on the esophagus. But you think about it. We don't think about this, right? We don't think about when we swallow. It's an automatic reflex, same thing like breathing. But if you had difficulty every time you tried to swallow something, you can imagine how that would be difficult.
Absolutely. And we swallow all the time. You don't realize it, but we have secretions, little pools that we swallow all the time. Now that I mention it, everybody's thinking about it.
I know.
Yeah.
I was like,
But that being said, we take it for granted. And now if it hurts or if things get stuck in the back of your throat, it can be quite impactful on patients.
Yeah, but the esophagus is one of those kind of, it's one of those organs we don't think about a lot, but it can, like you say, it does its job in the background. We don't think about it, but when it doesn't function, it's really very concerning and obvious.
That's true for so many parts of our health,
Right.
that we take it for granted, and then you don't realize how much you use it and rely on it until it's not working right.
That's right. So what are the main symptoms someone would come to you who had a cervical spine or a disorder, let's say?
So the first thing is pain. So a lot of us carry all our stress and our, in our shoulders and in our pain, and we're just so tense up there. And if you ever get a massage or go to a massage, most of us are just so tight because we have such high stress lives nowadays. We're walking around like tin soldiers.
Yeah.
And all that stress and muscular tension affects our neck and our shoulders. And so neck pain, like back pain, is very, very common. So we were talking about all those masquerading symptoms and things like that, but the most common symptom is pain. And a lot of people have neck pain. Now, thankfully, the vast majority of those are going to get better with non-operative treatments. And we talked about our good friends, the physical therapists last time. And we rely on them heavily for the low back, and we rely on them very heavily for the neck.
You know what I've seen a lot in our Black Friday sales?
Yeah.
Are those massage like cloaks, I guess you would call it, just kind of like it's like a shoulder collar. And it's supposed to be really good for neck pain. Is that one of the interventions like you would use as, I'm not saying that exact contraption, but like that heat and like a little bit of massage?
So heat is very helpful in helping these things, and massage. Unfortunately, again, another obstacle placed in front of us by our insurance carriers is that they don't usually pay for massage. They'll pay for some physical therapy, but physical therapy is more focused on strengthening and flexibility. So most people are paying out of pocket. But if you have the means to get a massage and a good deep tissue massage in your neck, that can be so helpful in relaxing the muscles and decreasing the tension there. So that can be very helpful. Heating pads can be also very helpful. And pharmacologically, we use anti-inflammatories and muscle relaxants to help us.
So with the heating pads, and I don't know if we talked about this, I can't remember with the back pain podcast or not, maybe you can remember. The dry heating pad heat, is that very different in the effect from the like wet, moist heat from like a shower or like that wet towel? Like a lot of times I'll do like a hot, wet towel in a garbage bag and like do something like that.
Yeah, and it works wonders. So in our last podcast with the low back, we talked about some people using ice and some people using heat. And I said there's no set rule.
Okay.
And the same is true for the neck. There's no set rule. However, in my experience, people have really reacted much better to heat on the neck because it really acts like a muscle relaxer. And we talked about all that tension that we carry around in our neck and our shoulders. And we're also on the computer all day and we're hunched over.
Yes.
All that. So one thing that's important is once you're rehabbing from that, some of the larger employers can offer a ergonomic consult.
Yeah.
So most of us sit in any chair and look at any computer screen, and about 95% of the time, our chairs are not set up right. Even though some of the more generous employers give us these very fancy seats with movable backrests and movable arms, and we never use it. We just sit down and start typing away.
Right.
And after the end of 8, 9, 10, 12 hours of that,
you're feeling it.
You're definitely feeling it. So actually having an ergonomic consult to make sure. So the rule of thumb is, think of everything as right angles. So your arm supports should be at right angles. You shouldn't be hunched. You shouldn't be sagging.
Okay.
Your workspace should be at a comfortable height so that your arms can reach it. Your keyboard should be below your desk. So, those fancy desks that have the little keyboard tray that we never use, and then we pop our keyboards on our desk. It's actually bad for your carpal tunnel, and it's also bad for your neck.
I hate
'Cause now
that you
you're
said
hunched
that.
up
I
the whole
hate those
time.
little trays under the desk.
You do?
Like, I never use
They're there for a reason.
Yeah.
Most of our keyboards are too high.
Yeah.
And your screen, your monitor.
Yeah.
Again, a rule of thumb is you should be looking straight forward at your monitor. If you're looking down or up, that's going to put strain on your neck.
Yeah.
Most of our monitors are adjustable, but people usually don't avail themselves of that. If your monitor's not adjustable, put a telephone book or a stack of books or a box underneath it so that you're looking straight, and that can really help.
Yeah. I mean, there are people who probably are sitting at computers 8 hours a day with their job, and
And then you go home, and I'm personally not a fan of laptops because the keyboard is attached to the screen.
Right.
So you can't have the keyboard at the right height and this monitor at the similar height because they're attached, right, by definition.
Right.
So you're either looking down, putting strain on your neck, or you have the keyboard up too high, putting strain on your shoulders and arms.
going back to the ice and heat thing, it's always fascinating to me because you can poll 20 different physicians. They'll have a completely different idea on this, and they feel so strongly about what's important. So what I usually will recommend to someone is probably similar to what you do. If it's an acute injury, I'll have them ice it for a few days. But then after that, I think heat is the way to go.
I agree. I think physicians can be dogmatic.
Yes.
And it's not even based on science or religion or faith. It's based on some sort of voodoo,
Right.
And once they get it in their heads, it's very hard to. I try my best to follow science-based and evidence-based medicine. However, I think I'm also probably susceptible to.
I think we all are a little bit, but
It's part of human nature.
anecdotally, I think the heat does seem to help most patients.
I agree, especially for the neck.
I agree. So one of the complaints patients come in with, of course, is pain. You mentioned that, but what are some other neck symptoms that someone might have other than pain or with pain?
So you can have pain, and then another giveaway to neck problems is developing numbness in the arms. If someone develops numbness in the arms, you really start want to think about neck problems. Doesn't mean that it couldn't be coming from something else. We do have things like neuropathy, or sometimes people could be having brain problems or mini strokes or things like that. But your provider should be thinking of neck problems if there's persistent numbness in the arms. And sometimes that comes without pain. And sometimes I have difficulty explaining the significance of the problem to the patient because pain bothers people a lot. However, numbness, people can usually live with a little numbness, but we talked about people being asymptomatic until the late stages.
Right.
So they may be ignoring that numbness or may not be bothering them that much.
Right.
And then when I tell them that they have severe pressure on the spinal cord, they, are often sort of doubtful of the gravity of the situation.
Well, you made an important point earlier, is that, the spinal cord itself, really, there's no sensation. You can cut into it, which, of course, you wouldn't want to do. But I mean, it's like cutting into the brain. There's no pain fibers once you get through the meninges, right?
Exactly right.
So yeah, I could see how someone could develop some narrowing of the spinal canal, some from arthritis and just degeneration, and they just all of a sudden they have weakness or they have numbness, and they may not have the pain that they would think they should have.
Right. And often people just are not sure what's going on. They feel their hands are a little more clumsy than usual. And trying to explain that it's coming from their neck can often be challenging.
Yeah, clumsy is not an uncommon symptom that people come in with.
Not at all.
They say, I just can't. I can't hold my utensils the same way, or my coffee cup, or write the same way.
The two most common clumsiness complaints I get is they can't button their shirt in the morning.
Yep, that one's true.
Yeah.
Or hold a heavy coffee cup.
Yeah.
They usually have their 20-ounce venti, and they just can't hold it.
They had to go from the extra large to the small.
Right.
Thank God. A sippy chart.
So, once they develop weakness, which the clumsiness is really kind of a sign of, that's really somewhat more advanced, I'm thinking.
Usually.
Yeah.
What's always surprising to me is the degree of compression and the symptoms. So sometimes people can have just a little bit of compression of their spinal cord and can have dramatic symptoms. And sometimes people can have horrific pressure on their spinal cord and they're doing pretty good.
Right.
Okay.
Yeah.
It's,
Why?
It's amazing.
One of those things about the body, you know.
So I have a couple of questions. And what's the time frame? Like, when you ice and when you use the heat and everything else, if this isn't getting resolved, am I waiting like a week or 2 weeks? Or let me give you a specific incident. I went on a ride at Disney and it was that plunge.
Oh, yeah.
Of like, you were like, why did I do this before you hit the bottom? But then like your neck's frozen, for like 2 weeks.
Oh, really?
It was a bad injury, but
Wow.
I'm just like, this will go away. And you're like, it's kind of not.
Wow. Did it hurt right away when you got off?
I knew I did something,
Yeah.
and then I couldn't like really put my arm down without it really hurting. I ended up going into the ER and I went on just pain medication. It went away maybe. It still acts up a little bit, but like how long should you wait with an injury to do all those things like the anti-inflammatories,
Physical therapy,
and that stuff before you're like, this just isn't going away? Like what is
So how long do you go with conservative treatment before
Correct.
you
That's a
move
better way
more
of asking that.
into a
Thank you.
surgical type of
Yes.
treatment course?
So as we discussed last time, there are really very few hard and fast rules. Everybody's different. So if you were on a roller coaster and you have a neck ache, then you can give it a couple of weeks and treat it with some Advil and some ice and heat and see if it goes away. If the pain is horrific, you should probably go to the emergency room and be checked out. If it's that bad, then maybe something's wrong or misaligned or dislocated. If you have, during our last podcast, we talked about red flags, numbness, weakness, inability to control your hands, or strange symptoms that may seem unrelated, like we talked about trouble walking. You're on a roller coaster, and a week later, now you're stumbling over yourself. That's when you want to be seen sooner rather than later, because those are those red flags that may be a sign. Because some people have pressure on their spinal cord, and they feel fine. They're those people who are completely asymptomatic. And then they go on a roller coaster, or they may just be in a light fender bender. Yeah. And that's the straw that breaks the camel's back, and all of a sudden they become symptomatic. And so it's something you don't want to just ignore.
Doctor, how come, when you have an injury like that, how come it will go away, but then it might, resurface again?
So this is something that is being studied with great interest by spine surgeons and neurology societies. And there used to be a feeling that if there was any pressure on the spinal cord, you had to treat it surgically right away. And we've found out through observation that you can actually watch people for a prolonged period of time. And as long as they're not getting worse, you don't necessarily have to operate. That being said, they should be followed carefully to make sure they're not getting worse. So they need close follow-up. But you don't always, and people can be stable with a certain degree of spinal cord compression for years.
What's the definitive test that you do for, when someone goes to see you with complaints, what are you ordering for them?
Quite often we order an MRI, but the most important thing, as you know, is sometimes just the laying of hands.
Yeah.
You have to look at someone, see how they walk, examine them, take a history, and pretty often you know what's wrong. It's we like to say that we order a test to confirm what we already know.
Makes sense.
If as a physician you're ordering tests, in a shotgun fashion, just spraying, hoping something turns up, usually nothing shows up because you're on the wrong track.
Right.
So you should make a pretty good,
I tell the medical students that all the time, that basically by the time you finish the history and the physical, you should know really what's going on for the most part. And then everything else is mostly confirmatory. I mean, there are some oddball diagnoses that you're not going to really obtain by history and physical, but you should have a pretty good direction.
Of course. And I couldn't agree with you more. I think, and especially in neurology and neurosurgery, that's very true. But by the time you're ordering the test, you should know what's going on. And just being evaluated, just laying of eyes and hands on the patient usually is the most important thing. And really, it's the practitioner who can determine, is this something that's urgent and really needs to be jumped on, or something that can be closely monitored.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So you see patients with neck issues that obviously have had injuries, acute injuries, but a lot of this stuff, I'm thinking is, from what I see at least, it's degenerative. It's related to age, wear and tear over many, many years. And that can be really insidious. I mean, that's the type of thing that patients can not realize how significant of an issue, as you mentioned, they have until it gets to a critical point. So it's just interesting. I mean, how we can kind of adapt to things.
Absolutely. I'm always astonished by the spinal cord and also by the brain that there can be pretty severe disease, and then you look at the MRI and see, pretty significant pathology, and then you look at the person in front of you and you say, I can't correlate these two pictures.
I mean, if you see a terrible MRI, but the patient doesn't have terrible symptoms, it doesn't necessarily require that they need surgery or anything of that nature.
Exactly right. And that used to be an old thinking, and then a lot of literature has come out recently over the past 10 years that says people with pressure on their spinal cord and their neck don't always have to go to surgery. They can be followed for some time as long as they remain stable.
I mean, it seems everyone over age, say 50, has neck issues. Like if you do an MRI, we're all going to have, anyone who's over 50 is going to have some degenerative change.
Absolutely.
It would be unheard of not to.
It would be unheard of not to. And unfortunately, sometimes the medical speak of the radiology report can lead people to think that, so it creates a lot of anxiety. If you look at a lot of MRI reports, as we do, the jargon, and for an individual who's not medically trained, they see the report and every single disc in their neck has something wrong with it. They think their head's going to fall off, and they're
not moving.
Yeah, they're on the phone with their doctor, that evening, like, oh my God, what's going to happen to me? So
that's one of the problems with. I mean, I think it's good in a way that patients can look at their results through the portal, but a lot of times they get really anxious.
Absolutely, and it's like any information.
For good reason.
Absolutely, But it's almost like any news report. News reports can be alarming unless you learn the context.
Right.
And so looking at your own health information is very important. I strongly agree with patients being involved in their own health care.
I agree.
They should be more involved and more, what's the word I'm looking for, more proactive in taking good care of their health. But that being said, sometimes if you don't understand the context, if you're not used to the language, the jargon that we use, it can cause a lot of unnecessary anxiety.
Absolutely, yeah.
So we've said a couple of things that are really good to know, like the ergonomically correct positions, especially if we're working on our computers, and being a little preventative, I guess, that way. Are there any other things that maybe we should definitely not be doing? Like maybe when we see those signs at the roller coaster, be like, yeah, maybe that is me they're talking about.
If the signs of the roller coaster are there for a reason, and they're a little bit stringent. So, I mean, I don't think, but obviously the roller coaster companies don't want to be sued.
Right.
But that being said, if you have a history of neck and spine problems, you probably shouldn't be on a roller coaster.
Okay.
Similarly, there is just some very easy things that we can do to prevent neck injuries. And one of the most dangerous things, we talk about arthritis, but there is a lot of neck trauma, and those come from car accidents. And I'm still amazed today how many people still don't want to wear their seatbelts.
Right.
And it's just so frustrating because there's really no reason. I just saw a patient the other day who told me that, at the age of 10, they were stuck inside a car, couldn't get out of their seatbelt. And I said, yeah, that certainly is true. But if you look at the number of times someone is stuck in a car due to a seatbelt versus someone who's ejected out of a windshield, it's probably 1,000 to 1, 10,000 to 1, 1,000,000 to 1. I don't know what the statistic is, but people should wear their seatbelts because in a violent accident, and it doesn't have to be very high speed, even at 10, 15 miles an hour, there can be significant neck trauma unless you're wearing that belt.
What happens in like a car accident, like when you get like whiplash?
So what happens is in the accidents, the body is thrown forward and either is restrained by the seatbelt or you hit something. Even an airbag doesn't help as much if you don't have your seatbelt, because as the body hits that, the neck and the head that's attached to it actually swings back and forth. So if you ever look at those crash test videos, you can see how many times the neck goes back and forth at its extreme.
Really true.
All the way back, all the way forward, all the way back, all the way forward. It's almost like it's a jack-in-the-box on a spring.
Right.
And when that happens, there's the slightest level of neck injury, which is whiplash. Whiplash is mostly muscular and skeletal, but with a little bit more force, you get into dislocations and fractures and things like that. And the neck is a very sensitive structure. It's not very robust and is prone to injury. And thankfully, the contact sports are paying more attention to neck protection.
Right.
And car manufacturers, you remember the days of the adjustable headrests? Now they give you that big headrest behind.
Yeah.
But unfortunately, if you're in an older car, a lot of people kept those headrests all the way down, just underneath, sort of behind the shoulders, which actually made rear-end collisions worse.
Oh.
Because people's heads snapped back.
They had no protection.
The headrest should really be behind your head to prevent any of that whiplash.
Interesting, yeah.
So if you notice, more modern cars have the big sort of big, taller, and they're less adjustable.
Yes.
So that they're always behind your head.
So what are the most common acute neck injuries you see? Motor vehicle accidents, you mentioned. That's probably number one.
Number one.
Falls.
Mm-hmm. And then we do see a fair number of sports injuries. Now, thankfully, sports injuries are among younger people who are more resilient and have less arthritis.
Right.
But football players, and you start looking at teenage and early 20 kids who think that they're invincible. And if they don't follow the rules and if they don't have the right protection, a lot of football players who are listening out there have all had stingers.
Right.
Where they, in football jargon, they call it spearing, where they tackle with the head.
Yes.
And good technique, you should tackle with your shoulder, not with your head. But if they use the head, they often will get sharp pain, pins and needles in their arms and their legs.
Or even temporary paralysis.
And temporary paralysis, exactly right.
It's quite frightening.
And it's very frightening. And we've seen it on TV, and it happens on the high school football fields, where a kid will hit someone else and they'll just be temporarily paralyzed on the field for, thankfully, just a few seconds, but sometimes it's a minute or more.
Those kids have to be, people who are into those types of sports have to be prone to arthritis in their neck as they get older, I think.
Yeah, I mean, all that repeated trauma.
Yeah. One thing I see periodically is someone who has a severe neck injury or head injury from falling downstairs.
Mm-hmm.
And it's generally, often it's the same story. They're going down the stairs and they just have their socks on.
Mm-hmm.
So they don't have shoes and then they slip.
Mm-hmm.
I actually see that probably every couple of years, someone with a really severe injury.
Yeah.
Yeah, absolutely.
Yeah.
Well, first of all, walking around the house in socks is just unless you have those socks with the little rubbers.
Drippy.
On them, yeah.
Exactly.
Yeah. Yeah.
Happy socks.
And if you think about it, it's really sort of a perfect storm.
Yeah.
So people who are a little bit more elderly tend to be more likely to fall.
Mm-hmm.
People who are more elderly are more likely to have arthritis in their neck.
Right.
And then the arthritis in their neck, if there's a little pressure on the spinal cord, causes them to have some numbness and some what we call loss of joint position sense.
Mm.
And so if they fall, they're a setup for severe injury. And the neck problem that they have is also making them more likely to fall.
Yeah, it's kind of both ways.
Exactly. So it's this vicious circle.
So we've talked about acute injuries, we've talked about kind of chronic degeneration, and all of this can sometimes lead to surgery if, I guess, conservative measures aren't appropriate or fail.
Mm-hmm.
Surgery must have come a long way over the last 10 years or 20 years, neck surgery per se. I'm sure it's nothing like it was in the past.
Absolutely right. And what's amazing is the speed of innovation actually seems to be accelerating. It seems like someone is coming out with a new technique or new operation almost yearly.
How do you learn all the new techniques?
You have to, I think all good physicians are dedicated to continuous learning and continuous improvement. I don't think there's one operation I do today that I do the same way I did when I was trained. So, as in many industries, physicians have continuous education and you have to keep yourself up to date. Attend meetings, read journals, and go to training seminars where you can learn new techniques.
I mean, for me, since I don't do procedures, it's fairly easy. I can, read some journals, go to a conference, but you have to go to training sessions,
Yes.
I would think, right, for new procedures that come out?
Indeed, but they try to make it in credit to, so the main societies for spine surgery are North American Spine Society, the American Association of Orthopedic Surgeons, American Association of Neurologic Surgeons, and Congress of Neurologic Surgeons. They work very hard to make sure that educational opportunities are available.
Right.
So if you go to a conference, quite often there are training sessions there.
Nice.
And then we have training seminars like the studio we're in right now
Right.
that actually have training locations so that surgeons don't have to travel too far and learn the techniques necessary to keep your skills up to date.
So we talked last time about how back surgery had changed in, the incisions are smaller, they're minimally invasive. I assume it's similar with neck surgery?
Very similar. So a lot of minimally invasive techniques, a lot of things that now patients can go home the same day. And
No, sir.
Yeah, so
Really?
people can have, and one of the things that's happening is not just fusing the spine, as is very common in the low back, but actually replacing the disc with a mechanical disc.
Holy
This-
moly.
Yeah, the same way that a knee is replaced. So people don't realize, but in the way back in the 60s and before, when people had terrible arthritis of the knee to the point that they couldn't walk on it anymore, they used to have their knee fused. And so they just, the knee joint would be just straight. And, if you sat down, your legs stuck out. But it got rid of the pain.
It just couldn't really function as well.
Exactly. So it was
Bending.
pain relief
Yeah.
at the expense of function. And then someone was smart enough to invent
Right.
a artificial knee. Well, a few years ago, people came up with an artificial disc for the neck. And the goal is the same, to preserve function, prevent people from having, bamboo spines,
Right.
and simultaneously allow for relief of pain. A recent landmark article came out just a couple of months ago that looks at 10 years of people with disc replacement versus disc fusion.
Oh.
And in terms of pain relief, it seems to have worked just as well. And in terms of need for reoperation, which was the goal, our hopes have been borne out that people who have had disc replacement have decreased need for further surgery in the future.
What about range of motion? Can they still, is that?
With an artificial disc, it's preserved. With fusion, there's a little bit of a decrease, but you have to remember there are 7 other bones and discs to compensate. So the loss of 1 or even 2 usually is not noticeable.
What do you do with patients who've had surgery years back and they had maybe extensive fusion done on multiple levels and now they have chronic pain? Are they candidates for disc replacement at this point or not?
No, usually once they've had extensive surgery, then really what we focus on is mostly function. So we work hand in glove with our pain management colleagues, and I'm fortunate enough to be part of a integrated spine center where there I have a couple of pain management doctors that work with me who are just phenomenal. Yeah. And they help with the pain using various techniques, including medications and injections and stimulators. And there are a lot of innovative devices that have come out to help people with pain.
I see some of these patients, and they've been my patients for many years, and they can really suffer quite a bit. They're on chronic opioids, and after a while, that doesn't work as well.
It can be horrific.
And they feel they've tried everything, but maybe they haven't. Maybe there are newer techniques out there.
There are newer techniques, and a couple of instances stand out in my mind where I've taken care of a couple people who have what we call chin-on-chest deformity, and they're just basically staring at their, staring at their lap or staring at the floor.
Like this.
So it could be
not good.
So sometimes it could be just simply from arthritis, progressive degeneration, and other times it could be a result of multiple surgeries, where each surgery their neck has sort of fallen down, and then by the 6th or 7th they're completely what we call kyphosed, or bent over. And one of the most satisfying experiences is to help those people. I remember there was this one patient that I took care of, and she cried because after surgery she was able to drink because she was never able to tip her head back. So she hadn't taken a drink from a cup. She had drank through a straw.
Right.
But she hadn't taken a drink from a cup in 10, 15 years. And just the ability to do that. So
all these things
10 or 15 years. So you were able to work with someone who had that long of a...
Yeah.
Wow.
Yeah, absolutely.
That has to be sad.
So what are, other than the disc replacement, are there other technological advances in neck surgery that have come about?
Yeah, so there's the disc replacement, but then also the ability to recorrect deformity with a fairly large procedure. But now the technology exists for us to put screws and rods in the back to provide that additional support. Because if you think about it, if someone has their chin on their chest, you have to basically cut through that bone to release it so that, you can get that person's chin up. But then how do you hold it in place? The techniques to do that were relatively limited, but nowadays you can stabilize the neck very robustly with screws and rods that essentially go from the top of the spine to the upper back. And it's nothing that's small, but when necessary, it can be life-altering.
How long does that surgery take?
It depends. So if you're going back to operate on someone who has had previous surgery, you have to go very slow. There's a lot of scar tissue there. It can be many hours. Mm-hmm. It's not unusual to have a 6-7 hour procedure.
It's a long time.
It's a long time. But if you have severe pain and it can help you out, makes sense.
I'm good with it if I'm the patient. That's a long time for a surgeon.
Yeah. So this was, we learned a lot today.
I have one last question. Okay, it's just it's a little baby simple question.
Yeah, sure, go ahead.
But sleep positions, does that
good question.
play into anything in your realm?
So it does. There are actually several pillows out there that are designed to try to keep your neck stable. And they provide some help. Unfortunately, when you fall asleep, your body's going to do what it wants to do.
Yeah.
So it's hard to stay in a certain position. And then when we wake up, we have a crick on our neck, and
Right.
it could be quite trouble.
All right, since we're asking that question, these are two very common questions I get. I'll ask you, since you're an expert at this. These are always questions that I try to answer the best I can, but I want to hear what you say. So people come in, they say, I don't really have any, usually younger patients, I don't really have any pain in my neck, but when I turn my head, it cracks or snaps.
Oh,
What does that mean?
Yeah.
So that is just like cracking your knuckles.
Right.
And there's a little bit of gas that forms in our joints, and it's just released when you move your neck certain ways. And unfortunately, and we've run out of time, we didn't really have a chance to talk about chiropractors, but
Oh, yeah.
sometimes,
Just a minute or two. That's
yeah. So if we do have time,
Yeah.
chiropractors can be very, very helpful in treating neck problems, but you need a good one, because with the ones that are a little bit more cavalier can harm as much as help.
Right.
So sometimes people think that you go to the chiropractor for the snap. And when you hear that snapping on your own, it's the same thing that the chiropractor is doing. They're just sort of mobilizing the joints and allowing for increased perfusion and nutrients and things like that. So a good chiropractor can be very helpful, but make sure that they've taken the time. How do you know who's a good chiropractor? They've taken the time to go through your medical record to make sure that you don't have any of those warning signs.
Nice.
If you do have those warning signs, do not have an adjustment. The deep tissue massage is great. The electrostimulation is great. Adjustment can be dangerous.
I mean, if someone has, for example, severe cervical spinal stenosis, I'm thinking they should not have
They should not be
not have
adjusted.
that, not be
Definitely
adjusted.
not. And most chiropractors who are judicious will not adjust. Again, they do a lot of other things. The deep tissue massage and the electrostimulation can be great.
Do you get into regenerative medicine at all? I find that a fascinating field. I don't know if it's used for cervical spine issues yet, like it is for large, joints, knee, hip, etc.
So it's in its infancy. There are a lot of studies looking at regenerative medicine and trying to use some of the same techniques for the joints and the spine.
Sure.
But I can't really tell you to use this or use that, because the science hasn't been around long enough to show benefit.
Right.
I really am hopeful that in the next 5-10 years we'll have great treatments to help that. But right now, it's just too early to tell.
Yeah, I agree. I mean, I've not seen anyone have a procedure done for their neck such as that. I mean, I see a lot of knee and hip issues and sometimes shoulder and that, where patients get involved with regenerative medicine.
Yeah, and they're currently experimenting on trying to inject those same regenerative drugs into the joints of the spine and the neck. But again, it's really in its infancy.
Yeah, very good. Nancy, you have any other questions?
I am done with my
All
questions.
right. Well,
I thought you had a second question.
yeah, you said you had a second one, didn't you?
No, it was just that sleep question.
Okay.
That was it, because I had like pillows in there, but you had answered that. So
Okay. Very good. Well, this was great. Thank you very much. I mean, there was a lot of really useful information that came
I hope so.
from this. We learned about, ergonomics at work. We learned about wearing your seatbelt in your car and having your headrest in a correct position. We talked a lot about acute injuries, and we talked about chronic injuries, how surgery has changed, and how you can help people that, maybe have given up on the medical field because they were told there was nothing else to do. And I guess the important part of all this is that they need to know how to contact you, because you may be able to help some of these
It's a great
people out.
segue.
So how do they contact you?
So I have offices both in Fall River and in Dartmouth, and there's a main number, 508-996-3991. If you have any spine issues, or even if you've been told that there's nothing anybody can do, sometimes it's worth it if you haven't seen someone in quite a while. It's worth a second look, because things have changed a lot.
Yeah. And I may have a few patients I'll send your way who are, you've had chronic neck issues that I think they've kind of given up, but maybe there is something that can be done.
Yeah, it's always worth it.
It's always worth a consult.
Absolutely.
Sure. Well, thank you very much.
Thank you for having me. It was a lot of fun.
Greatly appreciate you having you here again, and
Pleasure
we'll have you back to talk about the brain next. Which
I'm looking forward
is
to it.
really fascinating.
Oh, I can't wait for that one. That's gonna be great.
Absolutely.
That might be a 2-part episode.
That could be. That could
It might be. I have a lot of questions.
We'll have if it's like this is a whole neurosurgery miniseries, which I love.
I know.
It's great.
Break off into our own little neuro podcast.
Yeah, there we go. So, well, anyway, everyone, thank you for listening to our show. And if you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to Ron Gamache for our intro music and the BioSkills of Northeast for producing our show. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit duncanhearing.com. And of course, Dr. Marcovici, thank you so much for being on the show. We greatly appreciate it.
Thank you for having me. It was a pleasure.